Hi, good morning. Welcome to STAT's video chat, a conversation on the coronavirus with Richard Besser. Thank you for joining us. I'm Helen Branswell, and in just a little bit, I'll be joined by Dr. Richard Besser to talk about the current state of the coronavirus pandemic, some of the social inequity that has become apparent during this pandemic, and what he thinks about the nascent efforts to try to restore the economy. I have questions, and I'm sure you do too. But first, a few housekeeping items. At the bottom of your screen, you should see several icons. There's a chat icon and a Q&A icon. Please use the chat feature to chat amongst yourselves or to send a message directly to the STAT team. If you're having any technical difficulties, that's where to tell us. Don't put your questions to Dr. Besser in the chat. I won't be monitoring it for questions. If you do have a question you'd like to ask Dr. Besser, please type it into the Q&A feature. We're going to start to take questions about midway through the conversation, and we'll try to answer as many as possible. You can also use the Q&A feature to view all the questions that have been submitted and upvote the ones you're most interested in having answered. So thank you again for being here. And with that, I'd like to welcome Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation and a former acting director of the Centers for Disease Control and Prevention, a role he held at the beginning of the 2009 H1N1 flu pandemic. Thanks for joining us, Dr. Besser.
Helen, it's great to be here. It's good to see you as always.
Thanks so much. So let's get right to it because there are quite a few questions. As you know, there's just a huge and growing desire, it seems, to find ways to return to some sort of sense of normalcy. People are hurting economically, and they're finding the distancing measures really hard to endure. You're sitting on a governor's council for the 7 states in the northeast of the country, and I think you're working to try to coordinate ways to move forward there. Can you tell us anything about that work and how that group is thinking?
Yeah, thanks, Helen. You know, first thing just to recognize, people are hurting. People are hurting economically. People are hurting by the direct impact of coronavirus on themselves, their family, their friends. The sense of national grieving that's compounded by the economic challenges. So I'm one of the New Jersey representatives on the Governor's Council for the region. And the goal is to make sure we're all working off of the same playbook. If you think about viruses, they don't respect borders. And so to think that one state can do something in total isolation and have no impact on what's going on next door doesn't make a lot of sense. We're a federalist nation, so states will determine what goes on within their borders in terms of reopening. But the more there can be consistency, similar triggers for reopening, conversation around things that are shared, like transportation. It wouldn't make sense for New Jersey and New York and Connecticut to do different things on transportation, given that many of those systems are shared. The other thing that I'm finding, we've only had 2 meetings so far, but I'm finding it's a really valuable place to raise issues of equity. And by that, how do we ensure that everyone has a fair and just opportunity for health and well-being? When I think about how we've come into this and how this pandemic is playing out, it hasn't been a high priority for our nation. When you look at who's getting hit hardest, Black Americans, Latino, Native Americans are dying at rates, 2, 3, and more times their proportion in the population. And if it were a high priority to ensure that everyone was able to do the things to protect their health, we wouldn't be seeing this. But for too many people in America, they're having to decide between staying home and protecting themselves, their family, and their community, or going out and earning money to put food on the table and pay the rent. And we need to ensure that as we're opening up society, we are ensuring that everyone has the opportunity to protect themselves and do the right thing. And I'm not hearing it playing out at the federal level, at the level that it should.
I know that's an issue that really interests your foundation, and I want to ask more about it. But what do you think can be done? Like, how can we protect people at the lower end of the economic spectrum? How do you ensure that they're safer than they currently are now?
Well, the first thing is making it a priority and doing the work, getting the data to be able to really look at the problem. Not every state even reports out data by race and ethnicity, and that needs to happen. The last time I looked, there are only 2 states that report out testing by race and ethnicity. What you want to see is that that all communities, all populations are being tested at similar rates, and that the rate of positivity is about the same. That'll give you a sense of how you're doing.
Right.
But there's a lot that can be done. If you think about just the basics of early recommendations, the recommendation from CDC, if you had mild illness, to call your doctor, don't go to the emergency room, don't crowd hospitals. Well, 28 million people in America don't have health insurance. And that number is skyrocketing as people lose their jobs, given how much health insurance is tied to jobs. So if you don't have a doctor, you're going to go to the emergency room and potentially get exposed. People of color have much higher rates of uninsurance or underinsurance. A lot of states are implementing drive-through testing. Well, if you don't have a car, how are you going to get there? And I think there are a couple other critical areas. The rates of underlying medical conditions, whether it's heart disease, lung disease, diabetes, are much higher in communities of color due to structural racism. Communities in which people live are different. Those communities that we've allowed to have less clean air, less clean water, you'll see higher rates of these diseases. The life expectancy in America can differ by decades based on the community you live in. So going in, there's differences. But I hear that being said as well, given that there's nothing we can do. There are also much higher rates for Black Americans, Latinos, being considered essential workers.
Mm-hmm.
So working in government, working in healthcare, working in food production, food service. We need to put the same attention to personal protective equipment for people in those areas as we are for healthcare workers, so that there's not the exposure. And then when people are exposed and they're asked to go isolate, the guidance says, to isolate at home away from others. Well, if you live in an apartment, or if you live in a household where there isn't an extra room or an extra bathroom, you're telling people to go home and expose their family.
Right.
Other countries have treated this differently. They're providing hotel rooms. They're providing rooms in dormitories from universities that are closed. If we considered it a high priority, we would be doing those things, and we wouldn't be seeing the same kind of impact on some communities that we're seeing now.
Right. I mean, people are often pointing to the fact that some underlying conditions are more common in Black and Latino populations. But I mean, I think that really ignores the fact that a lot of people are working in those communities, are working in jobs where they can't work at home. I've been working at home for like 2 months now. Some people do not have that luxury. And I don't feel like as a society, we're doing a great job in ensuring their protection.
I think you're right. We're not doing that. There's a big differential in terms of ability to work remotely. For me, working remotely is inconvenient. For some people, it's absolutely impossible. It doesn't exist. And if it doesn't exist, and if people are doing things that are absolutely essential to keep society going, keeping food in our stores, running our transportation systems, keeping our government going, working in healthcare facilities and other places, we need to thank them, and we need to provide protection. And we're not doing that. We're not making it a high priority. And this, if we don't pay close attention to this, as states are reopening, we're going to see skyrocketing rates of disease in the same populations, because it's what's called a predictable surprise. You can see it coming, and then when it happens, everyone says, "Wow, I never knew that was going to happen." But it is going to happen, and we can't allow that.
One of the things that I've found sort of puzzling about this whole thing is the lack of sort of a national response. You know, you mentioned before that some countries have isolated cases or quarantined their contacts in sort of dormitories or central holding facilities of a sort, fed them, you know, ensured that they could be taken care of in a place where they're not a risk to other people. But here that's not being done. And if it is being done anywhere, I know Seattle, for instance, bought a hotel at a point to put people up, but it's, you know, piecemeal. It's somebody might be doing it in one state and or in one county and not across the line. Does that hurt the country's efforts to try to get on top of this, that there isn't a really coordinated response?
Well, you know, I think that we need to see the standard set at the federal level. It really concerns me that we're not hearing from CDC every day. We're not hearing from them what they consider to be the best practices in terms of isolation and quarantine, what needs to be done. We're seeing so much that's being presented to us by political leaders. And when that's the case, you know, half the country says, great, I'm on board, and the rest rejects things out of hands because of who the messenger is. The more you can depoliticize a response, the more successful you're going to be. I led emergency preparedness and response at CDC for 4 years. And, you know, as we would work with Congress and try and get resources and make the case for the importance of our public health system and investing in public health, we tried to do it in a way that resonated across the aisle. And we could do that. But it was clear that during a response, the more you could see things coming forward from Congress, from state houses that were bipartisan, where there was, you know, joint support, the better you were going to be. And what we're seeing play out here in many ways is it's getting a little hyper-partisan.
The message has become completely politicized. It's quite stunning to me, because this virus doesn't care anything about how anybody votes. It's just looking for throats, and you know,
yeah,
who those throats support. It doesn't care at all. You mentioned the CDC. I remember very well in 2009, at the start of the H1N1 pandemic, you know, you had daily briefings as the acting director, and I would be dialing in and hearing you folks talking about the, you know, best practices, what you were learning. I remember at a point schools were closed, and then at another point you realized school closures were hurting more than they were actually helping, and that decision was reversed. We're just really not hearing from them at all. They have not had a briefing since, well, it's approaching 2 months now. How damaging is that to the country?
I think it's detrimental for a number of reasons. You know, early on, in particular, during a new public health threat, what you don't know far surpasses what you do know. As you learn, it means that you're going to change what you recommend. If you're not able to have that daily dialogue, that back and forth, sharing what you know, what you don't know, what you're doing to get new answers, when you put out new guidance, it seems like you're either indecisive, or you're flip-flopping, or you don't know what you're talking about. You know, one example here, CDC early on recommended no masks, and then came forward and recommended masks. It would have been really helpful for them to be out there explaining, well, here's why we changed that. Here's what we thought before. Here's what we learned. And here's what we think you could do with a mask. It doesn't replace the other recommendations because the science isn't really strong, but we do think it might add a little value. That's very different from what we saw coming down in terms of how that guidance was released. Right. The other piece of it is during 2009 and H1N1, the questions that we got from media, which were the same questions the public wanted to know the answers to, it made our work better. You know, we had to answer those questions. We didn't stop a briefing until we'd addressed all of the questions in the room. And it challenged our assumptions. It made us think harder. And, you know, you can get into a very insular groupthink mode when you're in an emergency operations center. Having those briefings with the press is really important for the nation.
Okay, so I wanted to ask you, you know, as I said earlier, states are, and as you noted, because you're working on that commission with the 7 New England states are starting to talk about reopening. Georgia, for instance, is moving ahead. They're allowing tattoo parlors to reopen. Beaches in California were crowded this weekend as the weather gets nice. Are we at the point where this is safe to do at this point?
Yeah, I mean, from a public health perspective, I don't think we are. You know, public health science should influence what's done. It's not the only thing that drives decision making around this, but it should be an important factor. I don't think we're seeing the data that we need to really understand the situation in states to be able to say that we should open. We're not getting data broken down by race and ethnicity. We don't have sufficient testing. You know, most places that do testing for COVID are testing people with really severe illness to determine, is it COVID? Do they need to be hospitalized for that? They're not able to test people with mild infection. And the reason that matters is that thankfully, most people who get COVID infection are going to do fine. But people with mild infection and even people without symptoms can transmit it to others. And if you
Right.
don't have the capacity to test those people, and you don't have the systems in place and the support to allow everyone to isolate or quarantine safely, and you don't have the public health system geared up to be able to do contact tracing, to identify everybody that someone sick has had contact with, so those people don't become part of that transmission chain. If you don't have all those pieces in place, as you reopen, you're going to see a rising number of cases, and you're not going to be able to handle it. You know, many of these states, I think, are only looking at hospital capacity and saying we've got extra beds in our hospitals, so if the numbers go up, we can handle it. These other pieces are critically important, and I haven't seen any states really lay out that they have all of these places, all of these pieces in place in order to be reopening.
Give me your thoughts on vaccine. There have been a lot of promises made. I mean, there are always caveats about, you know, it remains to be seen whether or not X type of vaccine will work. But people have, I think, been given the impression that, you know, a year to 12 months is the time frame for vaccination. And I wonder if that's overpromising. What do you think?
Yeah, I mean, you know the literature and the history on vaccine development, and you know, I hope there's a vaccine. I'm thrilled that there's as much effort going into looking at different approaches to vaccination and developing vaccines. But you know, there are a lot of viral infections where scientists have been working for decades to try and make vaccines where we don't have them. We don't have an effective vaccine against HIV. We don't have one for dengue fever. You know, these are diseases that that have killed millions of people. So I hope there'll be a vaccine, but there's no guarantee. And so our you know, the planning has to consider the possibility that there will never be a vaccine for this, or not one in the time frame that matters. There's a lot of discussion in the news lately about antibody testing. Antibodies are the protective factors that our bodies make after exposure to an infection that provide some protection against future infection. Well, for this coronavirus, it's still to be determined whether someone who gets the infection one time can get it again. It's not clear whether antibodies are protective, whether they're fully protective, how long they last. There's so many different antibody tests that are out there. We don't know that they're measuring the same thing. But if we are going to see an effective vaccine, I find it hard to believe that there will be an effective vaccine if natural infection doesn't give you some degree of immunity. I don't know of any diseases where it's the case where a vaccine protects you, but getting the natural infection does not. So there's a lot to be learned there, and I'm hopeful about a vaccine. Right now, I think so much of the coverage is driven by press releases from companies that are making vaccines that have to do with stock price rather than the reality of knowing that there's a product that's going to be safe and effective. And safe is critically important. You know, there's this sense of rushing vaccines to market. This isn't like influenza where we can just plug in a different strain into an existing type of vaccine. This is one where the work has to be done to truly show it's safe and effective. Because we do have over the course of history times where vaccines that looked promising were actually harmful.
So I'm going to go to some of the viewer questions now, and one that's up at the top here gets to that whole issue of why exposure to the virus, if it doesn't cause immunity, the vaccine. You just said you didn't think that's possible, but with flu, we don't have lifetime immunity, but flu shots do mitigate, do help provide some protection. And they do, I think, also mitigate severity of disease. Is that maybe a model for what a COVID vaccine might do? I mean, it might be something that we have to have booster shots at points or whatever.
Yeah, I mean that's a possibility. But with flu, when you've had one strain of the flu, you do have some degree of protective immunity going forward, at least for some period of time, against that strain. My point was that if there's no protective immunity whatsoever from having a natural COVID infection, it's hard for me to think that there'll be any degree of protection from a vaccine against that strain. Maybe using different approaches, novel approaches, there's a way around that. Mm-hmm. But the questions around immunity are, what pattern of antibodies provides protection, and for how long? Is it right. Something that's almost lifelong, like you see for measles? Is it something like for flu, where you have to get a vaccine every year in order to get protection?
Okay. A viewer named Zane has asked, is there hope for change in how healthcare is delivered after we get through this pandemic? On the one hand, I feel that it will fundamentally change delivery. And on the other hand, I feel like the legacy players like insurers and hospitals will push for the status quo more strongly. Your thoughts?
Well, pandemics over the course of history have had roles in reshaping society. And I think we'll have an opportunity, I hope we'll have an opportunity coming out of this to say, what kind of society do we want to have? What kind of safety net? The safety net in America is in tatters. One of the areas where there are incredible gaps and major equity gaps is around health insurance. 28 million people without health insurance, differences there by race and ethnicity. In America, everyone should have access to high quality, comprehensive, affordable healthcare. I would love to see coming out of this universal healthcare. I think there'll be more acceptance for things like telehealth. But again, let's make sure that's available everywhere. It's available in community clinics that serve lower income populations, as well as clinics that serve people with more resources.
Okay, I'm just going to give you folks a reminder that if you want to ask a question, please put it into the Q&A. Please don't put it into the chat. I'm not drawing questions from the chat. Here is a question from Doc/Mark L. Prominent university presidents are arguing for universities to open in the fall. Your feelings about business as normal for colleges and universities?
Yeah, this is one of the areas that in the regional group there's discussion that we need really a national approach to this. It's a little early to say what the fall will look like. We don't know yet whether this virus will decline this summer as the humidity rises and the heat rises, and then whether it will then see a resurgence in the fall like we see with some other viruses. But I think the planning for the fall is going to have to take into account that not everyone has the same degree of risk, and not everyone has the same degree of risk tolerance. And so planning for what school could look like. Could it look like the opportunity for that some students would be on campus and some would be remote, decreasing density on campus in terms of dormitories and classrooms, taking steps to protect staff who may actually be at higher risk than students. There's a lot of thinking, and I know that there are higher education groups that are thinking this through. It's another area where getting guidance from CDC is going to be really, really important to drive what happens across the country.
Okay. Viewer named Leslie asks, why would a second wave potentially dwarf the first wave?
Well, at this point, we don't know how much disease has come through communities. What happens with natural infection is that once a sufficient number of people in a community have had the infection, if they cannot get it again, that's another big if. You get something called herd immunity, where it's harder for a virus to travel through the community because they hit all of these roadblocks. People who've had it before who can't get it again. Once we have sufficient, we have antibody testing that can answer the question, how many people in a community may be protected, we'll be able to say more about that. But, if say, 5%, 10% of people in the community have had this, if you reopen and people are circulating, there's still a lot of people who could still get this. And if it hits us in the late fall during flu season, you have the added challenge of two respiratory viruses that can cause major problems for people's health and for the healthcare system hitting at the same time. So that's where some of the concern lies with the second wave.
Right. Someone named Phil asks, what do we know scientifically about the virus strain and how it differs from other coronavirus strains? Is this a question that you feel like you can answer?
Yeah, that's not really my strength. I know that the virus is being monitored for mutations. Mm-hmm. With flu viruses, mutations matter in a big way in terms of whether a strain can come back and hit people again. There's a lot of work looking at that. They're looking at the molecular level in terms of tracking viruses. That's given a lot of information to public health in terms of where this virus may have first started in the US. Scientists are looking at these strains to see what animal species they may have come from, because that's really important in terms of how new diseases emerge. But right. That's probably about all I should say on that.
Okay. I think it's important to note that viruses do mutate. That's what they do. And it's not, mutations in and of themselves are only important if they change the behavior of the virus, allow it to evade a vaccine or allow it to evade a drug or become more or less severe. So I think, people should be expecting to hear that there have been mutations, because they're going to be. Lisa Fitzpatrick asks how your foundation's funding strategy has shifted to directly address the health inequities revealed by the pandemic. Is the foundation making changes?
Well, there are a lot of things we're doing differently. We put out $50 million early on for direct humanitarian assistance. And we did that because of just the scale and scope of this health crisis, but also to call attention to groups who are being hit really hard, whose needs aren't being addressed fully by the federal government. So domestic workers who do so much throughout our communities, but may not be eligible for money through the CARES Act. People with disabilities. There are major issues for people with disabilities that far surpass the issues for others, and ensuring that people who come into homes to help people with disabilities have protective equipment, that people have sick leave, so that if a home care worker is no longer available, family members can stay at home and take leave and get paid for that while they're caring for someone who has a disability. Working to ensure people with disabilities and all can get 90-day prescriptions. That's really important if you're trying to ensure people are not out and about as much, especially given people with disabilities have more direct needs in terms of drugs. So with that humanitarian assistance, calling attention to some groups, immigrant groups, people with color who are being hit hard. In terms of our general grant making, we've just like other philanthropies, we've moved towards much more flexibility, allowing grantees to take their grant money and use it for general operating support. As a philanthropy, we put a lot of effort into the area of policy change. And we're hoping that coming out of this, we're not just doing these short-term fixes, but we're addressing things like universal health care, paid sick and family leave. We're one of the only wealthy nations, that doesn't have a national standard for sick leave and family leave. Unemployment insurance, broadening that so that more people have access to that. We put a lot of emphasis around housing and the importance of housing when it comes to health. We want to see policy change in that area. So things like low-income housing tax credits are expanded to encourage more mixed income and low-income housing in areas where communities are being rebuilt. And then food insecurity. One of the issues we raised up very early was the challenge as schools were closing the tens of millions of kids whose meals come from the school lunch program, looking and pushing to expand the SNAP, the Supplemental Nutrition Assistance Program, so that there's fewer requirements and broader expansion. So we see this right now as the issues that we care about deeply as a philanthropy. You can see them everywhere as critically important to how people do during this crisis, and then beyond that, what kind of society we want to see.
Okay. Ed asks, hospitals are hemorrhaging cash due to the cancellation of non-elective surgeries and high-cost beds occupied by low reimbursement patients. How do we protect hospitals when reopened, a second wave occurs, demanding the use of these now occupied beds?
Yeah, I mean, that's one of the reasons why it's so important to not go too fast with reopening. You have parts of the country that are just coping with the number of patients who have COVID-19. You want to make sure there's enough room to take care of patients with COVID-19 and other people with healthcare needs. One for survival of hospital, but more importantly, think of all the patients who have cancer whose surgery has been delayed. People with breast cancer, colon cancer who haven't been screened and don't know that they have cancer. People with diabetes and heart disease and kidney disease. These are critically important health issues that aren't being met right now because the system is so taken up by COVID. And again, these are areas where low-income communities of color are bearing a disproportionate burden because if you look at healthcare services in lower income communities, they're much less robust than you'll see in other places.
Someone named John has asked about your sense of COVID-19's infection fatality rate. And for viewers, I'm just going to explain that infection fatality rate means the number of people who die of all the people infected, including those who have really mild or even not, asymptomatic infection. So he's asking about your thoughts of the possible undercounting of the numerator and denominator in calculating the rate. I know there's a lot of interest online about this, and a lot of people think that this risk has been overplayed effectively, that at some point in time, the infection fatality rate will be shown to be somewhere in the order of what the case fatality rate of flu. Is that a valid question? And do you have a sense of where this is settling in?
Yeah. I don't think we know what the case fatality rate is. And I think it is important to know what that is. In terms of the numerator, I think there's an undercounting of deaths from COVID-19. For a long time, only patients who tested positive were counted. And given how much undertesting there was, a lot of people were dying from illness that was totally consistent with COVID-19 and they weren't being counted. In terms of the denominator, we're grossly, I think, underestimating the number of people or undercounting the number of people who have had COVID-19 because thankfully so many people do well with this. But it only takes looking at the hospital system in New York City to, I think, blow up the argument that we are overreacting to COVID-19. When you see the pictures of what's going on in a lot of those hospitals, it's clear that this is a very serious health threat, that it will continue to be a very serious health threat for a long time. And until we're seeing the numbers of people who are being hospitalized and dying from this going down substantially, I think it's really hard to make a serious case for overreaction. I do think that it's important to recognize that when pandemics hit, they don't hit everywhere at the same time in the same time course or with the same degree of intensity. Mm-hmm. And so it does make sense going forward that different places are loosening the restrictions on movement and activity at different rates. That's totally appropriate, but you want each place to do it based on sound public health principles and then apply those based on what's going on locally.
Right. Just one thing, I'd ask you to talk about the attack rate. You know, when people are looking at how many people die, and as you point out, we don't know that yet. I think that the argument about this being not much more than seasonal flu ignores the fact that every year only between 8 and 11% of people get symptomatic seasonal flu.
Yeah.
Because we all have some immunity to flu from past experiences, and we may have flu shots or whatever. We're all susceptible to this virus. It's you would just expect a different kind of dynamic, would you not?
Yeah, I mean, you talk about this and write about it so clearly. You know, this is a virus coming into communities that are what are called naive. It hasn't been seen before, and so unlike flu, which causes significant illness and death every year, when flu comes through, there's only a subset of the population who's really at risk of getting that because of previous experience with flu. What happens, you know, when you see one flu strain, next time a similar flu strain comes through, you get some cross protection from that. Here with this coronavirus, there's a lot we don't know as to whether there is cross protection at all from other coronaviruses, but what we're seeing is broad susceptibility across the population, across age ranges. Thankfully, you know, not everyone is at risk or at the same level of risk for severe disease, for fatal disease. And the actions we're taking are really about protecting those people who are at greatly increased risk, the elderly, people with certain underlying medical conditions. But we're doing it for them because we recognize that everyone plays a role in transmission. But you know, one important science question that we really need to address that hasn't been addressed is what role children play in disease transmission. Right. You know, we're taking steps in terms of control based on what we know from influenza. And if that's true, you know, children for influenza are critically important means of spreading this within communities. They spread it to each other very readily, and to elderly people who are at great risk. We don't yet know that for coronavirus, and finding out the answer to that's important because it can affect when you decide to reopen schools and other places where children gather.
Yeah, it's actually something I want to write about, but it's a bit of a challenge because in so many places schools were closed, and so you can't really gather the information. When the WHO went to China to look at the data from China, they said, oh, children aren't amplifying this infection. But it's like, well, but children were already on lockdown by the time you got there. They were at home. So of course they weren't the people bringing the virus into the home. And you know, I'm not sure where you could actually get the data at this point to sort of answer that question.
I think it is challenging. It's one of those things that as you move forward and you start to reopen, if you have planned studies, you may be able to look at that. So you can see as you're starting to open childcare centers so that workers can get to work and their kids are cared for. You can look to see whether those childcare centers become a focus for transmission. But it is really important. Shutting down schools is such a barrier to reopening many aspects of society. And if it's necessary, then it should be continued. But if it's not, and you know, another place to look is at countries that have already started to reopen schools. What can we learn? What's being learned from some of the Scandinavian countries where they're reopening schools with some social distancing between desks? Does that you know, affect things?
Right. Do you have, Fred asked, are there countries, states, regions that have the best model for reopening that you know of?
Well, there's a lot of work going on across states that all are based on very similar principles of reopening from the public health side, making sure that there's sufficient testing to be able to test for mild cases, isolating people who are positive and providing services and support. Not just a place to stay, but income. A lot of people, if they're told to quarantine for 14 days, they're not going to get paid. Well, the government should support people so that they can do the right thing. Contact tracing, and that means gearing up across the nation, potentially hundreds of thousands of trained people. And those people need to come from diverse communities. There's a lot of distrust of the public health system in many communities, and justified. due to histories of racism in the public health system, racism in our healthcare system. Ensuring that people who are doing contact tracing come from a wide diversity of communities is really important. The communities are engaged in understanding why the approach that's being taken is being taken, and then quarantining individuals. You're hearing these pieces. The other part is that as industries reopen and sectors reopen, that those sectors have worked together on a shared approach to worker safety. So that, when construction's coming online, those groups that represent the large construction firms have all agreed how that will be done. For manufacturing, the same. For each of the sectors, there's approaches. Thinking about restaurants, let's make sure that restaurant workers are protected as we think about reopening restaurants, because that's another area where there are a lot of lower income workers, workers of color, and you would hate to see the desire to get restaurants, retail, other areas open if we haven't been able to determine what are safe practices, what type of protective equipment is needed so that everyone can be protected during this.
Okay, I'm just going to try to sneak in one last question because I think we're going to be out of time. But Joy asks, would you recommend getting an antibody test if you had what you thought was the flu earlier this year? I know that a lot of people got ill in sort of late November, early December, and really wonder whether or not the virus was here a lot earlier. Do you think that the antibody tests or the serology tests are far enough along at this point to be useful on an individual level like that?
Yeah, from my perspective, I would say they're not ready for prime time. At some point in the future, there may be value in that. And I think less for November, December than if you had something from February to now, wanting to know, did you have COVID? As we learn whether that means you are protected in the future, there could be value in that. But I worry that some countries are already moving forward with immunity passports or cards. The science isn't there, and that's the point WHO was trying to make. The science isn't there yet to be able to say what those tests mean. Until we have that, I worry that people will get a false sense of security and maybe change their behavior based on the results of that test, or have a false sense of concern if it's a test that isn't detecting protection that they may actually have. So I would say stay tuned on that one.
Okay. So I think we're going to be out of time, but thank you so much for being with us today and agreeing to answer the questions. And my apologies to the people whose questions we didn't get to. We could probably be here for another hour or more, but this has been really useful. Thanks so much, Rich, for making the time.
Helen, thanks so much for having me. I really appreciate it.
Okay. Thank you, everyone.